I'll reassure you, because when you have a session by Novo Nordisk giving us the topics and the headlines, one saying weight loss is extremely important. The cutoff value brought down to 23, and see, it's a hype, the topic given to me. So, this is what spices up, I think, a session, right? When you have completely a contrarian, topic given to me to talk about. So now the reason is, if you have other agents coming up in the future with a greater weight loss, what happens to semaglutide? So that's where this panic sets in and this sort of topic comes up. But there is some truth to it also, which I'll go through. Now, is it entirely related to the product? Is the weight loss, the cardiovascular benefit? I'll be exclusively talking about the cardiovascular benefit of the products. Because remember, the EASD were empagliflozin, which is, I think, the session just before this one, where the people rose on their on their feet and clapped, because first time ever an anti-diabetic molecule showed that there is a cardiovascular benefit. We were stunned because we always depended on an aspirin or a beta blocker or a statin for cardiovascular benefit. We never depended on an anti-hyperglycemic molecule doing that. But those were later on proven to be effective molecules from heart failure and kidney perspective. Hardcore MI and stroke benefits were seen with GLP-1. Now, is it entirely related to GLP-1? So suppose we treat someone without a GLP-1, do we get similar benefits if we don't treat them with GLP-1, if they have an equivalent cardiovascular risk? So is it entirely about the molecule, or metabolic, reduction of metabolic diseases are important? Is blood sugar lowering important? Is blood glucose lowering important? Is blood lipids lowering important? Or is just putting on the molecule which is important? Now, we did this in 2022, and we presented this meta-regression analysis in DRCP, and we showed that near about 22, we call it the rule of 22. The 22% of mass reduction is attributed to 0.9% reduction in HbA1c, exactly what UKPDS told us. UKPDS could not show that there is macrovascular benefit, but we could replicate that. So the GLP-1 benefit was not without glucose control. You just cannot leave someone with a bad glucose control and put on a drug and say, okay, you'll have your cardiovascular benefit. You will have to use combination of agents along with GLP-1. We will have to achieve good glycemic control. It is not without a good glycemic control. What is interesting is we showed that all these trials done with GLP-1 were extremely heterogeneous. They had different HbA1c ranging from 7.2 to 8.9. So suppose a trial which had an HbA1c of 8.9, the sugars fell down by a lot. So how can you say it's only about the GLP-1? So sugar lowering also had an effect. And then the duration of trials. Remember, a Rewind trial went up to 5.3 years, whereas some of the trials were only 1.1 or 2 years. So there was extreme heterogeneity of the data, which was statistically significant. And we found no correlation between weight reduction or systolic blood pressure reduction and the cardiovascular benefits, but the entire benefits were driven linearly by reduction in blood sugar. So, treating a diabetic patient, if you're telling a diabetologist that sugar reduction is not important, well, why do you even practice as a diabetologist from the very next day? So, it's extremely important that glucose control is important. Then you bring on board a GLP-1, it makes sense, right? But also remember, the baseline mean HbA1c, the systolic blood pressure was 120 to 130. So how can I even explore the thing that reduction of blood pressure is not important? Had they recruited patient with a systolic blood pressure, say, of 160, then we would have understood this story. The same thing with weight. Today we are talking about weight reduction, but those days, morbidly obese people were not included in the trial. So when we say that probably weight loss or systolic blood pressure reduction was not responsible for the MACE benefits, these trials were not even designed to look into it. So we can't say that weight loss is not important. Then why is this paradox? We are saying that weight loss is not translating into cardiovascular benefit. Where is this paradox coming from? Now, on one hand, the AAC, this is the last year AAC guideline, and this January we have the ADA, obesity algorithm, and both are saying you need at least a 10% of weight loss from baseline to have cardiovascular benefit. And if you look here, from red to orange to yellow to green, which means the more you lose weight, the more you get cardiovascular benefit. Now, if it is true, then why do we see that when we speculate, suppose you keep on increasing your weight loss by introducing agents like dual agonist and triple agonist, you get a linearly higher degrees of weight loss. This is our paper in the obesity, which is the official journal of the Obesity Society in USA, and we showed that if you go from a plain GLP-1 like semaglutide to a dual agonist like tirzepatide to a retatrutide, you have an incremental amount of weight loss. And not only that, there's a significant reduction in waist circumference. Now, what's the value of all those things if this doesn't translate into any outcomes benefit? So, in order to explore that, we are presenting the data till date, whatever outcomes had been done in this year's Munich European Society of Cardiology, when weight loss is not the whole story. So, where is the story? We have been told that with incremental weight loss, you get incremental cardiovascular benefit. And the topic given to me by Novo Nordisk is this a myth? So let's explore. What we found that there is an inflection point of 3 kilograms of weight loss. Up to 0 to 3 kilograms, we find that there is an incremental benefit. After that, there is a saturation point. Any additional weight loss does not translate into cardiovascular benefit, which is why the reason is because of the pleiotropic effects of GLP-1 on endothelial dysfunction as well as on the inflammatory parameters starts working from day one. So you get all those benefits when you're losing weight initially. So you get those early benefits. Thereafter, weight loss does not bring about any further changes on the endothelium or on the inflammatory markers. Now, where this 10% came from? This 10% baseline weight loss came from the look ahead trial. This was done on patients who were put on diet and exercise. They were followed up intensively and they did not find any benefit of lifestyle on cardiovascular outcomes. Absolutely no benefit. But when they did a post hoc analysis, they found those who lost at least 10% of their baseline weight, these were the individuals who had cardiovascular benefits. So this is where this 10% story came from. It was from the Look Ahead trial. So it's time now we talk about cardiovascular benefits from two perspectives. Whether we are going ahead with a weight loss without GLP-1 on board, for example, lifestyle, bariatric surgery, etc., or we are looking at weight loss with GLP-1 on board. If GLP-1 is on board, then even modest weight loss can give us cardiovascular benefits. So if you look at a leader trial, a mean weight loss of 3 kilograms gave us mass reduction, gave us cardiovascular death reduction. In pre-diabetes select trial, 6.5 kilograms of mean weight loss gave us the mass success. So there's a huge heterogeneity in the weight loss parameter that we are seeing. So these are more than 1 lakh participants whom we analyzed across all these trials, including Surpass CVOT, Select Trial, Soul, and everything. And what we show, there is a saturation point. The benefit when GLP-1 is on board starts from day one. And as you start losing weight, it goes on giving you benefit till near about 3 to 3.5 kilograms. Then there is a saturation point. So the more weight you lose after that, you already acquired your cardiovascular benefit. You don't get any. We will answer after this. So this is the algorithm that we are talking about. If you have a model in which you have lifestyle and or bariatric surgery, it is weight loss per se. Because of weight loss, because of those restructuring of your adipocytes, reduction in visceral adipose tissue, you have an impact on your endothelial function, you have an impact on the inflammatory markers. That takes time because it is a long duration process, and then you get the metabolic changes and the cardiovascular benefit. But if you bring on direct pleiotropic benefits, like with the GLP-1 on board, you get the benefit early on, and then weight loss takes a backseat. It's not that weight loss is not important, which is the next part of my slide, because this patient might have an MASLD, which requires a huge amount of weight loss to get those benefits. So the argument seems to be using a dual or triple agonist and going for more than 15-20% weight loss, which I think Binagda was trying to impress upon you, is useless from a cardiovascular perspective, because you're reaching a plateau at 3 to 3.5 kilograms. And that is probably completely supported by the Surpass CVOT trial. Just 2 days back, Melanie Davis gave an editorial on the metabolic perspective saying how superior tirzepatide is over a semaglutide. 11.6% additional superior weight loss compared to a semaglutide. More than near about 1.6% additional HbA1c reduction compared to a semaglutide. 6.2 millimeters of mercury additional systolic blood pressure reduction compared to a semaglutide, but it could not even defeat a dulaglutide when it came to MACE. Absolutely same. So probably it is supporting the story that we are trying to tell you, that the inflection point is reached at around 3 to 3.5 kilograms. And this is the very recent Lancet paper looking at the post hoc analysis of the SELECT trial, which was done with semaglutide. And they found only 4% of the MACE could be explained by body weight reduction. Pathetic. But as Binagda was saying, let's look at waist circumference. 33% of MACE reduction could be explained by a reduction in waist circumference. It is extremely important that waist height ratio should now replace looking at BMI or any other things. Even doing a DEXA or or tests like MRI can be easily overcome by just doing waist height ratio, and it is universal throughout the world. It is not a different definition across population. 1.5 is a cutoff point. More than 1.5 is abnormal. Whether it's a Caucasian or an Indian, it doesn't matter. So waist height ratio should come big times in the near future. So I think one of the clinical takeaways from a cardiovascular perspective is modest weight loss is sufficient to capture majority of cardiovascular benefit. If our patient do not lose more than 10% of weight loss, we should counsel them, do not be discouraged. Your cardiovascular protection is in place even with those modest weight loss. We need to redefine success. Do not deem a therapy failure simply because you don't achieve your weight loss targets from a cardiovascular perspective. And we need to understand that just stepping on the scale is not good enough. There are other organs in the body. It's like that famous surgeon's quote: "Operation successful, patient dead." What is the point of a successful operation if the patient is dead? So if I protect the heart and the liver goes for a toss or the kidney fails, what's the point? So this is a very important slide. I'll just ponder on this for a few minutes. There are different types of fat. There are different types of fat volumes in different types of organs, and their metabolic activity is completely different. The cardiovascular fat or the outcomes is dependent on epicardial adipose tissue. Normally, the volume of epicardial adipose tissue is 80 to 120 ml. Mark this, 80 to 120 ml. Normally, the fat in the liver is 1 liter, right? 1000 ml. So if I need a cardiovascular benefit in individuals who have 150 ml, I need to bring down that by just 30 milliliters to get cardiovascular benefit. Get that 3 kilograms of weight loss is good enough. But in order to reduce, in steatosis, the liver stores 2 to 2.5 liters of fat. You need to reduce near about 1.5 liters of fat. You need more than 10 to 15% of weight loss to get those benefits. For a pre-diabetic patient, the entire visceral fat is around 3 to 6 liters. Now I need to bring the 6 liters down to 3 liters to prevent our pre-diabetes not to get converted in the type 2 diabetic patient. Imagine the amount of weight loss required. 15-20% weight loss will be required. So if we look at a person, we cannot just look at an individual only from a heart's perspective. Because person also has a liver, person also has a pancreas, person also has a kidney. So we cannot say that just 3.5 kilos weight loss is good enough. We have given them cardiovascular protection, but we have to strive for greater weight loss to protect the other organs. So there are two timelines here. From cardiovascular outcomes, you have a rapid, timeline where immediately you get the pleiotropic benefit, and then there is a stagnation. But from a metabolic benefit, when GLP-1 is not on board, we have a slower timeline because weight reduction without a GLP-1 on board, systolic blood pressure reduction, sugar reduction takes time. So it is a slow and ongoing process. So the final take is we had moved away from a glucocentric view to an organ-centric view. We are probably going into a pleiotropic-centric view. We'll need to look at the organs. And remember, we always had the GLP-1 and SGLT2 based trials, CVOT trials done on patients who did not have organ dysfunction, who did not have MASLD, who did not have renal dysfunction. Now, if you have a MASLD on board, MASLD is an independent risk factor for MACE. So we don't know whether, from if we had patients with established cardiovascular disease and MASLD, whether they would have benefited with a much larger weight loss. These are very myopic view with diabetic patient plus ASCVD. All other organs are normal and they were tried in most of the CVOT trials. This is the latest ADA algorithm. And you see, when we started, the first algorithm came in 2026. We went to Siliguri to present that data. We remember 2006 by Nathan and Buse. We had just one algorithm. You have diabetes, you have sulfonylurea, metformin, basal insulin. That progressed, and slowly we had ASCVD, heart failure, and now look, see, it's a never-ending table. Pre-diabetes, type 2 diabetes, hypertension, ASCVD, MASLD, OSA, and you find class A recommendation even for hypertension with semaglutide everywhere. There's only one place where tirzepatide is toppling semaglutide, which is OSA. But I think OSA is also dependent on weight loss. These are just, positioning given by our authorities. We can use any drug which causes you weight loss. And pulmonologists rarely refer to us because then the CPAP machine will go out of use. But I think if they do refer to us, we can do a better job. So the final slide of mine is, it is not a hype. I think from a cardiovascular perspective, it looks like weight loss looks like a hype, but it's not a hype. It's a reality. It's an upstream, therapeutic target. If we catch them early and we start treating them early on, I think we can prevent a lot of complications in the near future. As of now, semaglutide is the evidence leader. It ticks all the boxes everywhere. Given a choice, if you have those organ dysfunction, it is more prudent to start with semaglutide. And you need additional weight loss in the future, we can think of switching over to the other drugs. Thank you.